Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Belantamab, Mafodotin, Bortezomib, and Dexamethasone for multiple myeloma. Background. Belantamab Mafodotin had single-agent activity in patients with relapsed or refractory multiple myeloma, a finding that supports further evaluation of the agent in combination with standard care therapies, methods. In this Phase 3, open-label, randomized trial, we evaluated Belantamab Mafodotin, Bortezomib, and Dexamethasone, BVD, as compared with Daratumumab, Bortezomib, and Dexamethasone, DVD, in patients who had progression of multiple myeloma after at least one line of therapy. The primary endpoint was progression-free survival. Key secondary endpoints were overall survival, response duration, and minimal residual disease, MRD negative status. Results. In total, 494 patients were randomly assigned to receive BVD, 243 patients, or DVD, 251 patients. At a median follow-up of 28.2 months, range 0.1 to 40.0, median progression-free survival was 36.6 months, 95% confidence interval. CI 28.4 to not reached in the BVD group, and 13.4 months, 95% CI, 11.1 to 17.5 in the DVD group. Hazard ratio for disease progression or death 0.41. 95% CI, 0.31 to 0.53, p less than 0.001. Overall survival at 18 months was 84% in the BVD group and 73% in the DVD group. An analysis of the restricted mean response duration favored BVD over DVD, p less than 0.001. Grade 3 or higher adverse events occurred in 95% of the patients in the BVD group, and 78% of those in the DVD group. Ocular events were more common in the BVD group than in the DVD group, 79% versus 29%. Such events were managed with dose modifications, and events of worsening visual acuity mostly resolved. Conclusions. As compared with DVD therapy, BVD therapy conferred a significant benefit with respect to progression-free survival among patients who had relapsed or refractory multiple myeloma after at least one line of therapy. Most patients had grade 3 or higher adverse events. Belantamab Mafodotin, Pomalidomide, and Dexamethasone in multiple myeloma. Background. Triplet or quadruplet therapies, incorporating proteasome inhibitors, immunomodulators, and anti-CD38 antibodies, have led to prolonged survival among patients with newly diagnosed multiple myeloma. However, most patients have a relapse. Frontline lenalidomide therapy has increased the number of patients with lenalidomide refractory disease at the time of the first relapse. Methods. In this Phase 3, randomized, open-label trial, we evaluated Belantamab, Mafodotin, Pomalidomide, and Dexamethasone, BPD, as compared with Pomalidomide, Bortezomib, and Dexamethasone, PVD, in lenalidomide-exposed patients who had relapsed or refractory myeloma after at least one line of therapy. The primary endpoint was progression-free survival. Disease response and safety were also assessed. Results. A total of 302 patients underwent randomization, 155 were assigned to the BPD group, and 147 to the PVD group. At a median follow-up of 21.8 months, range, less than 0.1 to 39.2, the 12-month estimated progression-free survival with BPD was 71%, 95% confidence interval, CI, 63 to 78, as compared with 51%, 95% CI, 42 to 60, with PVD. Hazard ratio for disease progression or death, 0.52, 95% CI, 0.37 to 0.73, p less than 0.001. Data on overall survival were immature. The percentage of patients with a response to treatment, partial response or better, was 77%, 95% CI, 70 to 84, in the BPD group, and 72%, 95% CI, 64 to 79, in the PVD group, 40%, 95% CI, 32 to 48, and 16%, 95% CI, 11 to 23, respectively, had a complete response or better. Grade 3 or higher adverse events occurred in 94% of the patients in the BPD group and 76% of those in the PVD group. Ocular events occurred in 89% of the patients who received BPD, grade 3 or 4 in 43%, and 30% of those who received PVD, grade 3 or 4 in 2%. Ocular events in the BPD group were managed with Belantamab Mafodotin dose modification. Ocular events led to treatment discontinuation in 9% of the patients in the BPD group and in no patients in the PVD group. Conclusions. Among lenalidomide-exposed patients with relapsed or refractory myeloma, BPD conferred a significantly greater benefit than PVD with respect to progression-free survival, as well as deeper, more durable responses. Ocular events were common, but were controllable by Belantamab Mafodotin dose modification. Autoantibodies targeting nephrin in Podocytopathies. Background. Minimal change disease and primary focal segmental glomerulosclerosis in adults, along with idiopathic nephrotic syndrome in children, are immune-mediated podocytopathies that lead to nephrotic syndrome. Autoantibodies targeting nephrin have been found in patients with minimal change disease, but their clinical and pathophysiological roles are unclear. Methods. We conducted a multicenter study to analyze antinephrin autoantibodies in adults with glomerular diseases, including minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, IgA nephropathy, antineutrophil cytoplasmic antibody-associated glomerulonephritis, and lupus nephritis, as well as in children with idiopathic nephrotic syndrome and in controls. We also created an experimental mouse model through active immunization with recombinant murine nephrin. Results. The study included 539 patients, 357 adults, and 182 children, and 117 controls. Among the adults, antinephrin autoantibodies were found in 46 of the 105 patients, 44%, with minimal change disease, 7 of 74, 9%, with primary focal segmental glomerulosclerosis, and only in rare cases among the patients with other conditions. Of the 182 children with idiopathic nephrotic syndrome, 94, 52%, had detectable antinephrin autoantibodies. In the subgroup of patients with active minimal change disease or idiopathic nephrotic syndrome, who were not receiving immunosuppressive treatment, the prevalence of antinephrin autoantibodies was as high as 69% and 90%, respectively. At study inclusion and during follow-up, antinephrin autoantibody levels were correlated with disease activity. Experimental immunization induced a nephrotic syndrome, a minimal change disease-like phenotype, IG localization to the podocyte slit diaphragm, nephrin phosphorylation, and severe cytoskeletal changes in mice. Conclusions. In this study, circulating antinephrin autoantibodies were common in patients with minimal change disease or idiopathic nephrotic syndrome, and appeared to be markers of disease activity. Their binding at the slit diaphragm induced podocyte dysfunction and nephrotic syndrome, which highlights their pathophysiological significance. Next, we will be discussing articles from Journal of American Medical Association. Projected changes in statin and antihypertensive therapy eligibility with the A.I.O Prevent Cardiovascular Risk Equations. Question: how many U.S. adults are estimated to experience changes in treatment eligibility when evaluated using the American Heart Association Predicting Risk of Cardiovascular Disease Events, PREVENT, equations versus the pooled cohort equations. Findings in this nationally representative study of 7,765 U.S. adults, aged 30 to 79 years, it was estimated that using Prevent would decrease the ERING number of U.S. adults receiving or recommended for statin therapy by 14.3 million and antihypertensive therapy by 2.62 million over 10 years. Reductions in treatment eligibility could result in an estimated 107,000 additional occurrences of myocardial infarction or stroke, meaning application of the Prevent equations to current risk-based treatment thresholds could reduce eligibility for statin and antihypertensive therapy among 15.8 million U.S. adults, with substantial implications for public health. Addiction consultation services for opioid use disorder treatment initiation and EngagementA, randomized clinical trial. Do interprofessional hospital addiction consultation services increase initiation and engagement in medication for opioid use disorder, MOUD, treatment after discharge? Findings in this stepped wedge cluster randomized clinical trial of 2,315 adults with opioid use disorder with hospitalizations in TUR. 6 New York, public hospitals, rates of post-discharge MOUD, were compared for patients admitted to hospitals providing an addiction consultation intervention versus usual care. Patients hospitalized during the intervention period had significantly higher odds of MOUD initiation, 7.96 times higher, and 30-day MOUD treatment engagement, 6.90 times higher, meaning the results of this trial found that interprofessional hospital addiction consultation services increased post-discharge MOUD use among patients with opioid use disorder who were not previously receiving MOUD treatment. Next, we will be discussing articles from Annals of Internal Medicine. Fatal and non-fatal firearm injury rates by race and ethnicity in the United States, 2019 to 2020. Background. Racial disparities in firearm injury death in the United States are well established. Less is known about the magnitude of non-fatal and total firearm injury. Objective: to combine healthcare data with death certificate data to estimate total firearm injuries in various racial and ethnic settings. Fatal injury data were collected from the Centers for Disease Control and Prevention. Data on non-fatal injuries were collected from the Nationwide Emergency Department Sample, NEDS, a 20% stratified sample of U.S. emergency department visits, weighted to provide national estimates for the United States, 2019 to 2020. Intervention. Race and ethnicity were classified into 5 mutually exclusive categories: Asian or Pacific Islander, Black, Hispanic, Native American, and White. International classification of diseases, 10th revision codes were used to classify firearm injury intent. Results. There were 252,376 total firearm injuries, including 84,908 deaths from firearm injuries. Of all firearm injuries, 37.8% were unintentional, 37.3% were assault-related, 21.0% were self-harm, and 1.3% were law enforcement associated. Self-harm had the highest CFRs, 90.9% overall. Unintentional injuries accounted for just 1,021, 1.2%, deaths but 94,433, 56.4%, of non-fatal injuries. Rates of self-harm were highest among white persons, 11.0 per 100,000 population in 2020, followed by Native Americans, 8.6 per 100,000. Rates of assault were highest among black persons, 70.1 per 100,000, as were unintentional injuries, 56.1 per 100,000. Conclusion. From 2019 to 2020, the total burden of firearm injuries amounts to an average of 1 injury every 4 minutes and 1 death every 12 minutes in the United States. Racial disparities in firearm injury death are mirrored in non-fatal injury. Next, we will be discussing articles from British Medical Journal. Intraosseous versus intravenous vascular access in upper extremity among adults with out-of-hospital cardiac arrest, Cluster Randomized Clinical Trial, Victor Trial Objective, to compare the effectiveness of intraosseous versus intravenous vascular access in the treatment of adult patients with out-of-hospital cardiac arrest. Setting the Victor venous injection compared to intraosseous injection during resuscitation of patients with out-of-hospital cardiac arrest. Trial involved emergency medical service agencies with all 4 advanced life support ambulance teams in Taipei City, Taiwan. The enrollment period spanned July 6, 2020 to June 30, 2023, and was temporarily suspended between May 20, 2021, and July 31, 2021, owing to the COVID-19 pandemic. Results among 1771 enrolled patients, 1732, 741 in the intraosseous group, and 991 in the intravenous group, were included in the primary analysis, median age 65.0 years, 1,234, 71.2%, men. In the intraosseous group, 79, 10.7%, patients were discharged alive, compared with 102, 10.3%. Patients in the intravenous group, odds ratio 1.04, 95% confidence interval 0.76 to 1.42, p equals 0.81. The odds ratio of intraosseous versus intravenous access was 1.23, 0.89 to 1.69, p equals 0.21. For pre-hospital return of spontaneous circulation, 0.92, 0.75 to 1.13, p equals 0.44. For sustained return of spontaneous circulation, and 1.17, 0.82 to 1.66, p equals 0.39, for survival with favorable neurological outcomes. Conclusions among adults with non-traumatic out-of-hospital cardiac arrest. Initial attempts to establish vascular access through the intraosseous route did not result in different outcomes, compared with intravenous access in terms of the proportion of patients surviving to hospital discharge, pre-hospital return of spontaneous circulation, sustained return of spontaneous circulation, and favorable neurological outcomes. Next, we will be discussing articles from Lancet. Safety and efficacy of subcutaneous Iscalimab, CFZ 533, in 2 distinct populations of patients with Sjögren's disease, twins. Week 24 results of a randomized, double-blind, placebo-controlled, Phase 2b dose-ranging study. Background. Sjögren's disease is a chronic autoimmune disease with an unmet need for targeted therapies. The aim of the twins study is to evaluate the safety and efficacy of Iscalimab, a monoclonal antibody against CD40, in patients with active Sjögren's disease. Findings. Between October 1, 2019, and February 28, 2022, 460 patients were screened. 173 patients were assigned to Cohort 1, 44 to Iscalimab 150 mg, 43 to 300 mg, 43 to 600 mg, and 43 to placebo, and 100 to Cohort 2, 50 to each group. In Cohort 1, the MCP step showed a significant dose-response relationship for placebo-adjusted ASTI change from baseline in one of 4 models. Linlog model, one-sided p equals 0.0041. ASTI decreased from baseline to week 24, with all 3 doses of Iscalimab, 150 mg and 600 mg doses showed statistically significant improvement. Placebo-adjusted least squares, LS, mean difference, 3.0, 95%, CI4.9 to 1.1, p equals 0.0025 for 125, 50 mg and 2.9, 4.9 to 1.0, p equals 0.0037 for 600 mg. In Cohort 2, ESPRI showed a trend towards improvement with Iscalimab 600 mg. Placebo-adjusted LS mean change from baseline 0.57 points, 95% CI 1.30 to 0.15, p equals 0.12. Serious adverse events were reported in 9 patients in Cohort 1, 2% of 43 in the placebo group, 2%, Of 44, in the Iscalimab 150 mg group, 3, 7%. Of 42, in the 300 mg group, 4, 9%. Of 44, in the 600 mg group, and 4 patients in cohort 2, 4%, of 50 in each group. No deaths occurred over the 24-week period. Interpretation. The study met the primary objective of demonstrating a significant dose-response relationship with Iscalimab in terms of disease activity at week 24. Iscalimab was well tolerated and showed initial clinical benefit over placebo in 2 distinct populations of patients with Sjögren's disease, to be confirmed in larger trials. Next, we will be discussing articles in the field of hemato-oncology. Here are the articles from Journal of Hepatology. Post-treatment LSM, rather than change during treatment, predicts decompensation in patients with cACLD after HCV cure. Post-treatment LSM is key for risk stratification in patients with compensated advanced chronic liver disease after HCV cure. Changes in LSM during treatment do not hold significant prognostic information in patients with follow-up LSM of 10 to 19.9 kilopascals. Thus, consideration of LSM dynamics is not of sufficient incremental value in the context of HCV cure. Post-treatment LSM should be used to guide clinical decision-making. Next, we will be discussing articles in the field of gastroenterology. Here are the articles from Clinical Gastroenterology. Effects of food insecurity on hepatic steatosis and fibrosis in people with HIV background and AIMS. Food insecurity, FI, is a risk factor for non-alcoholic fatty liver disease, NAFLD, and advanced fibrosis in the general population, but its impact on liver disease in people with HIV, PWH, is unknown. Methods. We examined the association of FI with prevalence of NAFLD and fibrosis in a diverse cohort of PWH. PWH. Greater than or equal to 18 years on antiretroviral therapy, HIV RNA, less than 200 copies per milliliter, and without other known liver diseases were screened for NAFLD, controlled attenuated parameter, greater than or equal to 263 decibels/meter, and advanced fibrosis. Liver stiffness measurement greater than or equal to 11 kilopascals by vibration-controlled transient elastography at 8 U.S. centers. Participants were categorized as food insecure using the 6-item short-form household food security survey. We used multivariable logistic regression to estimate odds ratios, ORs, and 95% confidence intervals, Cs, of NAFLD and advanced fibrosis by FI status. Conclusions. FI is highly prevalent among PWH and associated with lower odds of NAFLD, and among PWH with diabetes, there is greater odds of advanced fibrosis. FI may contribute to hepatic fibrosis through mechanisms other than steatosis in PWH. Vedolizumab, adalimumab, and methotrexate combination therapy in Crohn's disease, explore background and aims. Although biologics have revolutionized the treatment of Crohn's disease, CD, an efficacy ceiling has been reached. Combining biologic therapies may improve remission rates. Methods. Explore, a phase 4, single-arm, open-label study, evaluated triple combination therapy with vedolizumab, 300 mg on day 1, weeks 2 and 6, and then every 8 weeks, adalimumab, 160 mg on day 2, 80 mg at week 2, then 40 mg every 2 weeks, and methotrexate, 15 mg weekly, in biologic-naive patients with newly diagnosed, moderate to high-risk CD. Endoscopic remission at week 26, primary endpoint, simple endoscopic score for CD, less than or equal to 2. Clinical remission at weeks 10 and 26, secondary endpoint, Crohn's disease activity index, less than 150, and incidences of adverse events and serious adverse events were evaluated. Conclusions. Combination therapy resulted in endoscopic and clinical remission at week 26 in 34.5% and 54.5% of patients, respectively, with no safety signal related to the treatment regimen. This supports further evaluation of combination therapy in CD. Next, we will be discussing articles in the field of infectious diseases. Here are the articles from Clinical Infectious Diseases. Community-acquired Staphylococcus aureus bacteremia among people who inject drugs, a national cohort study in England, 2017 to 2020. Background. People who inject drugs, PWID, are at increased risk of community-acquired Staphylococcus aureus bacteremia, CA-SAB, but little is known about clinical outcomes of CA-SAB in POID compared with the wider population of patients with CA-SAB. Methods. 3 national datasets were linked to provide clinical and mortality data on patients hospitalized with CA-SAB in England between January 1, 2017 and December 31, 2020. POID were identified using the International Classification of Diseases, 10th Revision Code for Mental Health and Behavioral Disorder, due to opioid use, F11. Multivariable logistic regression was used to estimate adjusted odds ratios, AORs, for associations of POID with 30-day, all-cause mortality, and 90-day hospital readmission. Conclusions. In this large cohort study of patients with CA-SAB in England, POID had lower odds of death in the absence of endocarditis, and lower odds of readmission within 90 days, compared to non-POID patients. This study highlights the overrepresentation of POID among patients with CA-SAB nationally. A randomized, double-blind, Phase 3 safety and efficacy study of ridinilazole versus vancomycin for treatment of Clostridioides difficile infection. Clinical outcomes with microbiome and metabolome correlates of response. Background. Exposure to antibiotics predisposes to dysbiosis and Clostridioides difficile infection, CDI, that can be severe, recurrent, RCD, and life-threatening. Non-selective drugs that treat CDI and perpetuate dysbiosis are associated with ARCD, in part due to loss of microbiome-derived secondary bile acid, SBA, production. Ridinilazole is a highly selective drug designed to treat CDI and prevent RCD. Methods. In this Phase 3 superiority trial, adults with CDI, confirmed with a stool toxin test, were randomized to receive 10 days of ridinilazole, 200 mg twice daily, or vancomycin, 125 mg 4 times daily. The primary endpoint was sustained clinical response, SCR, defined as clinical response and no RCD through 30 days after end of treatment. Secondary endpoints included RCD and change in relative abundance of SBAs. Conclusions. Although ridinilazole did not meet superiority in SCR, ridinilazole greatly reduced RCD and preserved microbiome diversity and SBAs, compared with vancomycin. These findings suggest that treatment of CDI with ridinilazole results in an earlier recovery of gut microbiome health. Next, we will be discussing articles in the field of rheumatology. Here are the articles from Arthritis and Rheumatology. Intra-articular mineralization on computerized tomography of the knee, and risk of cartilage damage, the multi-center osteoarthritis study. Objective. Intra-articular, IA, mineralization may contribute to osteoarthritis, OA, structural progression. We studied the association of IA mineralization on knee computed tomography, CT, with cartilage damage worsening on knee magnetic resonance imaging, MRI, with a focus on location and tissue-specific effects. Methods. Participants from the multi-center osteoarthritis study with knee CT and MRI scans were included. Presence of IA mineralization on CT was defined as a Boston University calcium knee score greater than 0 anywhere in the knee. Cartilage worsening on MRI was defined as any increase in the MRI OA knee score, including incident damage. We evaluated the association of whole knee, compartment-specific, medial or lateral, and subregion-specific, location-matched, IA mineralization at baseline with cartilage worsening, at 2 years follow-up in the corresponding locations, using binomial regression with generalized estimating equations, adjusting for age, sex, and body mass index, BMI. Conclusion: CT detected IA mineralization in the cartilage was associated with higher risk of MRI cartilage worsening in the same compartment and subregion over 2 years. These findings suggest potential localized, tissue-specific effects of IA mineralization on cartilage pathology in NE-OA. Next, we will be discussing articles in the field of cardiology. Here are the articles from journals of the American College of Cardiology. Apixaban versus aspirin, according to CHA-2Ds, 2-VASC score, in subclinical atrial fibrillation, insights from Artesia. Background: Artesia, apixaban for the reduction of thromboembolism in patients with device-detected subclinical atrial fibrillation, demonstrated that apixaban, compared with aspirin, significantly reduced stroke and systemic embolism, SE, but increased major bleeding in patients with subclinical atrial fibrillation. Objectives: to help inform decision-making, the authors evaluated the efficacy and safety of apixaban according to baseline CHA-2Ds 2-VASC score. Methods: 1. Performed a subgroup analysis according to baseline CHA-2Ds 2-VASC score and assessed both the relative and absolute differences in stroke/SE and major bleeding. Conclusions: 1 in 4 patients in Artesia with subclinical atrial fibrillation had a CHA-2Ds 2-VASC score greater than 4 and a stroke/SE risk of 2.2% per year. For these patients, the benefits of treatment with apixaban in preventing stroke/SE are greater than the risks. The opposite is true for patients with CHA-2Ds 2-VASC score less than 4. A substantial intermediate group, CHA-2Ds 2-VASC equals 4, exists in which patient preferences will inform treatment decisions. Semaglutide and NIHA functional class in obesity-related heart failure with preserved ejection fraction, the STEP-FPF program. Background: in the semaglutide treatment effect in people with obesity and HFpF, STEP-FPF program, semaglutide improved heart failure, HF, related symptoms, physical limitations, and exercise function, and reduced body weight in patients with obesity-related heart failure with preserved ejection fraction, HFpF. Whether semaglutide improves functional status, as assessed by NIHA functional class, is unknown. Objectives: the goal of this study was to examine the effects of semaglutide on change in NIHA functional class over time. We also investigated the effects of semaglutide on HF-related symptoms, physical limitations, and body weight and other trial endpoints across baseline NIHA functional class categories. Methods: this was a pre-specified analysis of pooled data from 2 international, double-blind, randomized trials, STEP-HFpEF and STEP-HFpEF type 2 diabetes, STEP-HFpEF-DM, comprising the STEP-HFpEF program, which collectively randomized 1,145 participants with obesity-related HFpEF to once-weekly semaglutide 2.4 mg or placebo for 52 weeks. The outcome of interest for this analysis was the change in NIHA functional class, baseline to 52 weeks. We also investigated the effects of semaglutide on the dual primary, confirmatory secondary, and selected exploratory endpoints according to baseline NIHA functional class. Conclusions: in patients with obesity-related HFpEF, fewer semaglutide-treated than placebo-treated patients had a deterioration, and more had an improvement, in NIHA functional class at 52 weeks. Semaglutide consistently improved HF-related symptoms, physical limitations, and exercise function, and reduced body weight and biomarkers of inflammation and congestion in all NIHA functional class categories. Semaglutide-mediated improvements in health status were especially large in patients with NIHA functional classes 3/4. Next, we will be discussing articles in the field of endocrinology. Here are the articles from Journal of Clinical Endocrinology and Metabolism. Comparison of the efficacy of ezetimibe combination therapy and high-intensity statin monotherapy in type 2 diabetes. Context: low-density lipoprotein cholesterol, LDL-C, lowering therapy is considerably important in preventing cardiovascular disease, CVD, among patients with diabetes. Studies comparing CVD, stroke, and mortality outcomes of low or moderate-intensity statins with ezetimibe combination therapy and high-intensity statin monotherapy in patients with diabetes remain lacking. Objective: this study compared the primary prevention effect of myocardial infarction, MI, stroke, and all-cause death between combination therapy of low or moderate-intensity statins and ezetimibe and high-intensity statin monotherapy in patients with diabetes using the Korean National Health Insurance Claims Database. Methods: patients aged greater than or equal to 20 years with type 2 diabetes and dyslipidemia were enrolled. The combination therapy of CRUSH, low or moderate intensity statin and ezetimibe, was compared with high-intensity statin monotherapy after a propensity score matched analysis. The incidence of composite outcomes, consisting of MI, stroke, and all-cause death and each component were analyzed. Conclusion: adding ezetimibe to a moderate-intensity statin in patients with type 2 diabetes has a greater LDL-C lowering effect and greater primary prevention of composite outcomes than that of high-intensity statin monotherapy. Next, we will be discussing articles in the field of neurology. Here are the articles from Neurology. Mechanisms of hypercoagulability driving stroke risk in obesity, a Mendelian randomization study. Background and objectives. Obesity is hypothesized to induce a hypercoagulable state that increases stroke risk. The molecular mechanisms underlying this association are largely uncharacterized. We aimed to apply Mendelian randomization to identify whether the association of genetically proxied body mass index, BMI, with cardioembolic stroke risk is mediated by changes in levels of circulating coagulation factors. Methods: genetic proxies for BMI and levels of circulating coagulation factors were obtained, respectively, from the Genetic Investigation of Anthropometric Traits Consortium, N equals 694,649, and DCO-D cohort, N equals 35,559. Genetic associations with cardioembolic stroke risk were obtained from the GIGAStroke Consortium, 10,804 cases, and 1,234,804 controls. We performed a two-sample Mendelian randomization analysis testing the association of genetically proxied BMI with cardioembolic stroke risk, genetically proxied BMI with levels of coagulation factors, and genetically proxied levels of coagulation factors with cardioembolic stroke risk. These estimates were carried forward to mediation and sensitivity analyses. Discussion: human genetic data support increased levels of factor XI as a mechanistic explanation for how obesity increases cardioembolic stroke risk. The clinical relevance of this association warrants further investigation within ongoing clinical trials of factor XI inhibition. Next, we will be discussing articles in the field of pulmonary and critical care. Here are the articles from Chest. The efficacy and safety of inhaled antibiotics for the treatment of bronchiectasis in adults. Updated systematic review and meta-analysis. Background: inhaled antibiotics are recommended conditionally by international bronchiectasis guidelines for the treatment of patients with bronchiectasis, but results of individual studies are inconsistent. A previous meta-analysis demonstrated promising results regarding the efficacy and safety of inhaled antibiotics in bronchiectasis. Subsequent publications have supplemented the existing body of evidence further in this area. Research question: to what extent do inhaled antibiotics demonstrate both efficacy and safety as a treatment option for adults with bronchiectasis? Study design and methods. Systematic review and meta-analysis of randomized controlled trials of inhaled antibiotics in adult patients with bronchiectasis. We searched Medline, Embase, the Cochrane Central Register of Controlled Trials, Web of Science, and clinicaltrials.gov for eligible studies. Studies were included if they enrolled adults with bronchiectasis diagnosed by CT imaging and had a treatment duration of at least 4 weeks. The primary endpoint was exacerbation frequency, with additional key efficacy endpoints including severe exacerbations, bacterial load, symptoms, quality of life, and FEV1. Data were pooled through random effects meta-analysis. Interpretation. In this systematic review and meta-analysis, inhaled antibiotics resulted in a slight reduction in exacerbations, a probable reduction in severe exacerbations, and a likely slight improvement in symptoms and quality of life in adults with bronchiectasis. Early deep sedation practices worsened during the pandemic among adult patients without COVID-19, a retrospective cohort study. Background. There is substantial evidence that patients with COVID-19 were treated with sustained deep sedation during the pandemic. However, it is unknown whether such guideline discordant care had spillover effects to patients without COVID-19. Research question. Did patterns of early deep sedation change during the pandemic for patients on mechanical ventilation without COVID-19? Study design and methods. We used electronic health record data from 4,237 patients who were intubated without COVID-19. We compared sedation practices in the first 48 hours after intubation across pre-pandemic, February 1, 2018, to January 31, 2020, pandemic, April 1, 2020, to March 31, 2021, and late pandemic, April 1, 2021, to March 31, 2022, periods. Interpretation. We found that among patients on mechanical ventilation without COVID-19, sedation use increased during the pandemic. In the subsequent year, these practices did not return to pre-pandemic standards. Here are the articles from the American Journal of Respiratory and Critical Care Medicine. High airway occlusion pressure is associated with dyspnea and increased mortality in critically ill mechanically ventilated patients. Rationale: airway occlusion pressure at 100 MES, P0.1, reflects central respiratory drive. Objectives: aimed to assess factors associated with P0.1 and whether an abnormally low or high P0.1 value is associated with higher mortality and longer duration of mechanical ventilation, MV. Methods: we performed a secondary analysis of a prospective cohort study conducted in 10 ICUs in France to evaluate dyspnea in communicative MV patients. In patients intubated for more than 24 hours, P0.1 was measured with dyspnea as soon as patients could communicate and the next day. Conclusions: in patients receiving invasive MV, abnormally high P0.1 values may suggest dyspnea and are associated with higher mortality and prolonged duration of MV. Next, we will be discussing articles in the field of nephrology. Here are the articles from Clinical Journal of American Society of Nephrology. Genomic testing in patients with kidney failure of an unknown cause, a national Australian study. Background: the cause of kidney failure is unknown in approximately 10% of patients with stage 5 chronic kidney disease, CKD. For those who first present to nephrology care with kidney failure, standard investigations of serology, imaging, urinalysis, and kidney biopsy are limited differentiators of etiology. We aimed to determine the diagnostic utility of whole genome sequencing, WGS, with analysis of a broad kidney gene panel in patients with kidney failure of unknown cause. Methods: we prospectively recruited 100 participants who reached CKD stage 5 at the age of less than or equal to 50 years and had an unknown cause of kidney failure after standard investigation. Clinically accredited WGS was performed in this national cohort after genetic counseling. The primary analysis was targeted to 388 kidney-related genes, with second-tier, genome-wide, and mitochondrial analysis. Conclusions: in this prospectively ascertained Australian cohort, we identified a genetic diagnosis in 25% of patients with kidney failure of unknown cause. Here are the articles from Kidney International Reports. Randomized controlled trial of intradialytic cognitive and physical training to enhance functional capacity. Introduction. Hemodialysis. HD. Patients frequently experience cognitive and physical impairments due to various factors, including age, comorbidities, and the demanding nature of the treatment. This study explores the impact of a 12-week integrated cognitive and physical training program on the functional capacity of patients on HD. Methods. A single-blind, randomized controlled trial was conducted with 44 patients on HD. Participants were divided into an experimental, EXP, group that received a combined intervention of intradialytic cycling and cognitive training, and a control, CON, group receiving standard HD treatment. The trail-making test, TMT, timed up and go, TUG test, and tug dual task test, tug dual, were conducted before and after the intervention. Conclusion. This study demonstrates that a 12-week combined cognitive and physical training program during HD sessions significantly enhances cognitive function and mobility in patients on HD. These findings suggest that integrated interventions can mitigate functional declines in this population and improve their overall quality of life. Further research with larger samples and active control groups is warranted to confirm and expand upon these promising results. Outcomes of early versus delayed anemia treatment in non-dialysis dependent CKD. Introduction. The association of hemoglobin level at treatment initiation with renal and cardiovascular outcomes in patients with anemia in non-dialysis dependent NDD, chronic kidney disease, CKD, is unclear. Methods. This retrospective cohort study utilized two Japanese databases, Medical Data Vision Company Limited, Tokyo, Japan, MDV, and Real World Data Company Limited, Kyoto, Japan, RWD. Patients initiated on long-acting erythropoiesis-stimulating agent, ESA, treatment were divided into early, hemoglobin levels greater than or equal to 9.0 grams/dl, and delayed, less than 9.0 grams/dl, treatment groups. The primary outcome was a renal composite, renal replacement therapy, greater than or equal to 50% estimated glomerular filtration rate, JUCFR reduction, EGFR less than 6.0 milliliters per minute per 1.73 square meters, and all-cause mortality and secondary outcomes were a cardiovascular composite, hospitalization by ischemic heart disease, including myocardial infarction, hospitalization by stroke and heart failure, and cardiovascular death, and components of the composite outcomes. Conclusion. Although the risk of renal events was not increased following delayed treatment of anemia in patients with NDD-CKD, the risks of cardiovascular events and all-cause mortality were increased, suggesting the importance of early intervention before hemoglobin falls below 9.0 grams/dl. P2Y12 inhibitors, refill gap, predicts death in Medicare beneficiaries on chronic dialysis. Introduction. Oral P2Y12 inhibitors, P2Y12I, are commonly used antiplatelet drugs in patients with end-stage kidney disease, ESKD, on chronic dialysis. Although gaps in prescription refills are quite common in patients with ESKD, it remains unclear whether P2Y12I prescription refill patterns are associated with adverse clinical outcomes. Methods. We used the United States Renal Data System, UCRD's, registry for patients with ESKD to capture new P2Y12I prescriptions from 2011 to 2015. The primary exposure was prescription refill patterns, and the primary outcome was all-cause death. Conclusion. Non-adherence to P2Y12I prescriptions is quite common and disproportionately affects minorities. Younger individuals with ESKD are independently associated with a higher risk of death. The odds of having a refill gap are decreasing for older patients who are more compliant than younger patients. Spectrum of kidney biopsy findings associated with methamphetamine use. Introduction. Methamphetamine, METH, is one of the most used drugs of abuse worldwide. However, there are few reports and series examining the toxic kidney effects of meth, and associated histopathological changes are not well described. Methods. We retrospectively identified 112 patients with a history significant for meth abuse, of whom 62 were using meth only, and 60 were using meth plus other drugs of abuse. Conclusion. Most patients with meth use present with acute kidney injury, AKI, and often have proteinuria associated with a wide spectrum of renal pathology.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.